Hello, everybody. Good morning, good evening, good afternoon, wherever you're tuning in from. I'm Shivani Reddy. I'm a vitreoretinal surgeon at Talley Eye Institute in the United States in private practice. Um, Thank you so much for having me. It's an honor to work with CyberSight and be here with you guys today. So when I was kind of trying to pick a topic, what to talk about here, I thought, let's just go directly to the belly of the beast. Let's talk about the one thing that no one likes, which is proliferative vitreoretinopathy or PVR. So PVR really is a condition that humbles, the one of the best retina surgeons. They essentially there's no really good treatment for this. The primary treatment is surgical. So I think that in order to really understand PVR, we have to look at the pathophysiology and the treatment modalities. So you're going to see that the slides are very detailed in case you guys want to go over these later. But we're going to be talking about all of these on a very high level here. So let's go ahead and begin. So first off, I have a question for everyone. How much experience do you have in the medical and surgical treatment of PVR? Okay, all right. So there's some good. So there looks like a wide variety of people kind of tuning in today. So all right, so we're going to start at the basics here, okay? So first of all, what is PVR? So PVR essentially think about it as an inflammatory process that is a maladapted um, wound healing response in the retina that goes rather excessive. So essentially, it's a series of complex cellular reactions that form fibrocellular membranes that eventually cause contraction. Um, so with PVR, it's the most common cause for failure of RD repair. These membranes grow and contract within the vitreous on either sides of the side of the retina, as well as in the subretinal space. Um, And they also cause intraretinal fibrosis that can prevent the retina from flattening even after removing all of the membranes. So the contraction of these membranes is what really leads to the reopening of treated breaks or creating new breaks in the retina and also causing macular distortion. And that leads to tractional retinal detachments. So here's another poll question for you guys. So locally, where you're from, what would you say the local incidence of PVR is in your patient population? Okay. So pretty, we're about the 5 to 20% is what we're seeing. Greater than 25%. Wow, I wonder where that's from. Um, yep. All right. So, um, the other question is, in your experience, from what you guys have seen clinically, what is the most common cause of proliferative vitreoretinopathy? Okay, so 34% of you said standard retinal detachment. Okay, and 39% vitreoretinopathies. Okay, all right. So as we can see, there's like a wide spread here depending on where you practice, where you're from across the world. Genetically, people are different, circumstances are different. So this is another big challenge with PVR management and treatment. So I just wanted to highlight that. Um, so the incidence reported, at least in studies across the board, is around 5 to 10%, which seemed to be the majority of what everyone was seeing. The incidence is largely unchanged in prospective studies over the past 25 years, even though we've had a lot of evolution of vitreoretinal surgery techniques. Post-operatively, about 75 to 80% of PVR shows up within a month after surgery, and 95% appears within 45 days. Now, this can vary, once again, based on patient population and individual surgeon experience. Anatomic success after PVR-RD surgeries is between anywhere from 45 to 85%, and functional success defined as Snellen vision of 20 to 2800 or better after PVR surgery is on 26 to 67%. So it's really not great, guys. There's a higher incidence with kids, and there's also a more rapid course in kids and young adults, and this is because they have higher cellularity in their PVR reactions. Um, After penetrating ocular injuries, PVR rates can be up to 45%. They seem to be lower with intraocular foreign body injuries, and this is mostly because these patients are getting surgery earlier to remove the foreign body. So what are the risk factors for PVR? So really, there's a whole bunch of risk factors here. Preoperatively, intraocular inflammation that's prolonged is a big one. The quality of qualities of the detachment themselves. So the number of breaks, the number of clock hours of the breaks, how large of an extent of an RD do you have? The pre-op, PVR rates, grade A, grade B, early on. Also, vitreous hemorrhage preoperatively. Cutaneous keloid scarring has also been shown retrospectively recently to predispose to PVR. Intraoperatively, you have vitreous hemorrhage formation, you have tears that are incompletely sealed, if you have a lot of pigment release when you're draining fluid, if you do too much laser or too much cryotherapy, or if there's vitreous loss. Postoperatively, prolonged inflammation. After surgery, multiple reoperations, use of shorter acting gas tamponades, or persistent traction on brakes. All of these can lead to post-op PVR. The only modifiable risk factor from the patient standpoint with all of this is cigarette smoking. So how does PVR form, right? That's our question really here. So another poll for you guys. I just want to see what you think is necessary for PVR formation. A, just RP dispersion, B, blood ocular barrier changes, C, vitreous hemorrhage, D, trauma, and E and F are a combination. So you guys tell me what you think. Okay, good. So most of you got this one. So yes, it is a combination of A and B. So the two factors that play into PVR formation the most are number one, intravitreal dispersion of RPE cells, and number two, breakdown of the blood retinal barrier. So we're going to delve a little more deeply into this. So step one, you have a retinal detachment, right? So once you have a retinal detachment, you have RP migration of these, we have RP migration onto the surface of the retina from underneath it. So what this does is it disrupts the outer blood retinal barrier, which is, the tight junctions of RP are a big part of this. But also the inflammatory and ischemic cascade that happens after that is going to lead to the breakdown of the inner blood ocular barrier, blood retinal barrier, with that's formed from the retinal capillary endothelial cells. So essentially, both your blood retinal barriers are disrupted, and you have all this leakage of all this inflammatory material coming from your bloodstream now into your retina that was previously protected from all of that. Um, so how does PVR form? We like to think of it as a nice circular linear process, and in some ways it is, but really it's not linear. All of the steps of PVR are happening concurrently, and really one step begets the other, and each step potentiates the next step in the cycle. So this is probably a more accurate schematic with double arrows with going each way, showing how PVR is formed. So we're going to go into this step by step. So first question to ask yourself is, why is vision limited after PVR, right? So we go in, surgically repair the retina, reattach it, peel the membranes. Why can't people see? So there are really two reasons for this. So the first one is reactive gliosis. So Mueller cells are the kind of the support structures of the retina, and they kind of regulate the microenvironment of the retina, right? So between the they grow from the photoreceptors all the way to forming the ILM. In amphibians and fish, these actually morph into progenitor cells for photoreceptors in response to retinal damage in studies. But that doesn't happen in humans. In humans, instead, they undergo something called reactive gliosis, where they form a glial scar. We don't really know the reason for this, but we think the reason is because it prevents further damage to the healthy cells over here while these cells are getting gliotic. But really, what's happening is this whole process is also pro-inflammatory. So it's releasing more cytokines and more growth factors, and that's causing further degeneration of these photoreceptor cells. So photoreceptor death, oh, sorry. So before we do that, so reactive gliosis, really what's happening here is the dying neuronal cell bodies in the retinal layers and in their axons are replaced by these glial scars. So number one, as far as we know, neurons should be able to regenerate. Well, they can, but they don't have any room to regenerate because the scar is obstructing the axonal regeneration. And also the signal transmission between the layers is just completely off because of this disruption. So all of that is reactive gliosis. So now let's talk about frank death of the photoreceptors. So when your photoreceptors, when you have a retinal detachment, your photoreceptors start dying at day 3. By day 3, about 20% of your photoreceptors are dead in the area of the detachment. By day 28, probably greater than 50%. And these are all with like in vivo studies, so we really don't know if, they're more protected in the actual eye or not, but this is what we have as far as research so far. There are many pathways that lead to this, but the biggest one to remember is apoptosis. So essentially, what's happening is you have ischemic retina, right? So the ischemic retina is releasing a bunch of cytokines while these photoreceptors are dying from the hypoxia and ischemia. You also have the blood ocular barrier disruption down here with the RPE, and that's allowing macrophages to migrate into the subretinal space. All of this together is causing a lot of oxidative stress to the existing photoreceptors and is just going to lead to further photoreceptor death. So it's just, perpetuating on itself. Most of this migration happens about 3 to 4 days in. So really, if you can repair the retinal detachment as soon as possible, a lot of these changes will stop, sometimes even reverse. So it's thought to be traditionally occurring in three phases, just like wound healing, right? There's an inflammatory phase, there's a proliferation phase, and there's the ECM or extracellular matrix remodeling phase. Once again, not linear, everything's sort of happening concurrently here. So the time frame is variable and it's difficult to study in humans, but mostly it takes 4 to 8 weeks to develop from the time of the retinal detachment. The RPE cells are thought to be the largest cellular component in the studies of PVR ERMs. They adhere to the basal lamina that's made up of type 4 collagen, and that's in their normal state. However, during PVR formation, TNF alphas, TGF beta, factors like these are released by the RPE and the circulating macrophages, as well as platelet-derived growth factor. And these actually stimulate the RPE migration towards the extracellular matrix and away from each other. And it also, all these factors favor adhesion to the matrix collagens versus the basal lamina of the RPE collagen. So that's what's really happening here. Also, TP53 levels in vitreous cells are downregulated by these inflammatory cytokines. Well, TP53 actually allows, it encourages apoptosis. So if these are downregulated, now you have all these migrating cells that are very resilient to dying, and they're very long, they live longer. So that also perpetuates PVR. Extracellular matrix, we talked about that. Now we're going to talk about EMT or epithelial mesenchymal transition. So this is thought to be the biggest pathologic process in PVR. So essentially what this is RPE cells take on more of a mesenchymal fibrocyte-like properties. So they start to migrate more, they start to contract more. And this is kind of facilitated by um, the matrix around these cells being cleaved by matrix metalloproteases they give a path for these RP cells to migrate outwards. So this is just a schematic of what happens. So essentially, the cell-to-cell adhesion is what's really keeping these RP cells together, and the signals released by that. So the first step is they lose their cell-to-cell adhesion, they lose their microvilli. Once the tight junctions are gone, the RP cells also lose their polarity, the apical basal polarity, where the nuclei are towards the base. After that, the shape slowly changes, and they start to migrate out of away from their basal lamina, essentially. They also take on more alpha smooth muscle actin expression, which makes them more contractile. So what's really stimulating all these? We're not going to go over each of these cytokines individually, but this is just a little review slide for you guys. Essentially, there's a bunch of blood-borne components. There's a bunch of components from the macrophages themselves, and from the differentiating cells. PDGF alpha receptors tend to be a very strong factor in kind of perpetuating the cycle because they induce a bunch of downstream inflammatory effects, and they cause reactive oxygen species formation, which also increases inflammation. So the cellular involvement, what kind of cells are involved? We kind of talked about glial cells already with the Mueller cell reactive gliosis. Hyocytes are also involved, and these are cellular components of the vitreous themselves. Um, the vitreous is basically a cellular except for the hyocytes normally. So these hyocytes, in the case of PVR, start to attract monocytes and macrophages, and they also undergo differentiation and release pro-inflammatory factors. Microglia are also upregulated in PVR. They're found more in inflammatory PVR than traumatic PVR. We've already talked about the blood-borne cells, what macrophages do. There are also T lymphocytes and B lymphocytes that are seen. Endothelial cells can also proliferate, migrate um, into the fibrotic membrane. So essentially, if you look at the PVR membrane, yes, you're going to find a lot of fibroblasts, but originally it was thought that most of these were just RP cells, but now they can come from any of these cell lines really. So it's seen that all of these cells have the potential to really differentiate. So ECM remodeling. So extracellular matrix remodeling is a big part of this. So essentially it's considered the culmination of the PVR process, but once again, it's happening from the start. So the extracellular matrix is made up of a bunch of collagens, proteins, etc., that allow scaffold formation for all these migrating cells. And that's what eventually happens. It forms these migrating cells essentially attach to this ECM scaffold. And because they've taken on these contractile properties, they start contracting, the membranes start contracting, they pull on the adjacent retina, and that's what causes the detachment. What are the PVR membranes actually made of? We kind of touched on this, but really early on, they're very cellular, but later on, it's mostly collagen. And the contraction of these membranes actually decreases with time because they become less cellular. Are they true membranes? Not really in the strictest sense, because when we think of membranes, we think of like um, a single sheet. We think of a very clear cleavage plane, but our PVR membranes are really incorporated and imbricated with the neurosensory retina, especially the inner layers. So if you're peeling PVR, if you watch this peel PVR, you see it's very easy to tear the retina underneath. It's very hard for these membranes to come off, and this is why, because they're really integrated into the retina. So removing PVR membranes from damaged hypoxic retina is really a challenge. Um, this is an interesting study that was done on eyes that underwent penetrating ocular trauma. So these eyes essentially, the penetrating ocular trauma created retinal detachments. Patients came in with these retinal detachments, and they kind of graded the PVR based on like, how soon after their trauma did these patients come in. So when they took in, they divided them into different groups based on their presentation. So patients that were around 21 days post-trauma. You can see here that the retinas. So what? I'm sorry. Before we go forward, what they did is they actually took samples of the PVR membranes themselves, and they also took samples of the adjacent retina in these patients when they went in to repair these retinas. So at day 21, you can see that the retinas are mostly cellular, and there's not a lot of collagen fibers in this image C here, which is an actual histology of the membrane itself. As you go forward to about 30 days, you see that the retinas, I'm sorry, now losing its cellularity a little bit, and you have neuronal degeneration here, and you start to see these blue fibers or collagen fibers deposit within the PVR membranes. Eyes that were operated around day 50, once again, we're getting more and more folding of the retinal layers here, more collagen deposition, and by the time I go out to day 180, there's a lot less there's a lot less actual retinal tissue here, more fibrocellular membrane. Between the arrows is where the retinal tissue is kind of concentrated. And here in image I, you see all these collagen fibers. So this is a great histological representation of what's happening during PVR. Vitreous cortical remnants are also a big part of this, so they're considered a critical factor in PVR formation. So, really, vitreoschisis, which is abnormal separation of the vitreous from the surface of the retina, occurs when the posterior vitreous separates off, but the anterior vitreous is left over. So you can see in picture D, instead of being smooth like it would be with the full vitreous separation, you can actually see a layer of vitreous there. So the hyalocytes in this vitreous end up causing more contraction and create more of a scaffold for PVR formation in these cases. Removing vitreoschisis is very difficult surgically. It's very time consuming, and it requires the use of triamcinolone to stain the vitreous. So let's talk about classification of PVR. That was just a summary of the pathophysiology. Now we're moving on to classification. So it was first described as massive vitreal retraction because it was thought to be more of a vitreous process initially. But then Macamer and Lacka showed that there was actually cellular involvement when they had monkey models, and that later changed the name to massive periretinal proliferation. Um, in 1983, the Retina Society classification basically updated this based on biomicroscopic findings. Um, However, it didn't really account for prognosis or surgical difficulty. This classification then underwent various iterations. And in 1991, there's an updated Retina Society classification, which we use today. I have the classification tables for you guys here to go over later, but I'm going to go over these stages here. So first we have grade A PVR. So that's really early PVR, right? So early PVR, you're going to see not a lot of changes. The vitreous is going to appear more hazy, and then you're going to see pigment clumping. This isn't a great It's very hard to show pigment clumping on photos, but I picked this one because this patient came in about 2 months after detachment. You can see kind of the retina's detached all the way through here. This is actually pigment on in the anterior vitreous behind his lens, and there was a lot of pigment inferiorly as well. Grade B PVR is a little less subtle. So what you really see here is vessel tortuosity starts to occur. You'll have inner surface wrinkling, some retinal stiffness, which is once again hard to see clinically at this point. But what a real giveaway here is rolled edges around the tear. So you can see here the tear edges aren't smooth. It's like they're rolled outwards. So that's a sign of grade B PVR formation. Another example of grade B PVR, this patient actually underwent retinal detachment repair. This is about a 1 month out from her vitrectomy with buccal procedure. There's a very strong family history of retinal detachments in PVR. You can see some light wrinkle formation here. About a month later, this patient came in looking like this. So really the wrinkle formation was the early sign that PVR was brewing here. And you can even see the vessel tortuosity that they talk about because of the pulling from the PVR membranes. Advanced PVR changes, you have at this point frank membrane formation and surface wrinkling, which causes star folds. So that's a star fold. These are star folds that you see here. And also, if there's enough formation of there's enough PVR membrane formation, it can contract the retina, causing a funnel RD that can be closed or open. And funnel RDs, because they're shaped like a funnel, form more due to these tractional forces multidirectionally. So this is grade C PVR. So this is essentially grade C PVR is divided into posterior and anterior. So posterior PVR can have focal, diffuse, or full thickness folds circumferentially. Um, these folds are still called star folds. You can also have subretinal strands. Now, anterior PVR essentially is going to cause anterior or posterior displacement of the vitreous base. And that's going to change the configuration of what happens to the retina. So this is a case of just diffuse posterior PVR. You can see star folds kind of forming 360 degrees here. This is another case of a patient who presented to me about 2 months post-op, and I'm sorry, 2 months after detachment, not post-op. And you can see a starfold formation down here adjacent to his large tear. And there's also starfold formation up here. This is a patient who presented to me with a 6 month history of vision loss. And this is more, this is what we would see in kind of final stages of PVR. The retina is all edematous. You can't really see details here, and it's kind of being pulled into a funnel configuration. Subretinal PVR can also occur either in band configuration as we see here, or it can occur kind of in a napkin ring configuration around the disc, which will pull the retinal tissue upward. It's difficult to remove once again, but essentially the contraction pulls the retina out and forward towards itself in these situations. All right, so we've talked about the pathophysiology and classification. Now we're going to talk about medical treatment. So let's see here. Which of the following medical treatments are routinely employed in the management of PVR? Okay. So this is kind of a trick question. I just wanted to see where the audience's head was at. But so I would say it's a combination of all of the above and none of the above, because none of these truly have been shown to equivocally work with PVR. Okay. So the medical treatment of PVR is very difficult. And the reason for this is there's no one clear pathway that we need to target, right? There's no one clear inciting event. It's a multi-level nonlinear process, as we talked about. So the targets typically are either cell proliferation or inflammatory signal blockage. Ideally, whatever treatment we employ should be a combination of both. A bigger issue with this is patients are presenting to us at different stages of PVR. So it's not like every retinal detachment patient we see comes in at day one and we can say, hey, let's block your inflammation. Or they all presented with grade C later stage PVR and we say, okay, let's block cell proliferation. We don't quite know clinically most of the time where they are. Most of this is with patient history. A lot of times exam doesn't reveal a lot either. So it's difficult to really find a clear medical treatment for this. There are a ton of different medicines that are being studied for this. I'm just going to go over all of these on a very high level. I have tables here for you guys summarizing the studies on all of these medications, but essentially, um, there's no clear treatment winner at this point. Okay, so corticosteroids, of course, this is a clear, very obvious target, right? So because corticosteroids are anti-inflammatory, anti-proliferative, reduce blood-retinal barrier breakdown. They do, however, interestingly have a dose-dependent relationship. So at low doses, they actually stimulate proliferation per certain studies, and higher doses, they inhibit proliferation. So corticosteroids were studied extensively. Really, triamcinolone, Ozurdex hasn't really been shown to have a difference in visual or anatomic outcomes. Prednisone did show, or oral prednisone administration, um, in patients with a primary RD that didn't have clear PVR yet, did show reduced cellophane maculopathy down the line at 3, 1, 3, and 6 months. But there's, once again, not a clear direction for this. 5-FU is a uracil analog that blocks DNA synthesis, and it's typically combined with low molecular weight heparin. Um, there was some reduction in post-op PVR in a prospective study done by Azaria et al. Other agents that are being studied as well, VIT-100, which is a chimeric ribozyme, colchicine, and also doxorubicin. All of these have an effect on DNA replication or cell proliferation. So Levin's retinoic acid, isotretinoin, vitamin A derivative. It's a vitamin A derivative essentially that inhibits cellular proliferation, and in vitro studies, it was found to inhibit human RPE cell proliferation. So there have been a couple of studies that have shown that it's effective in modifying the course of PVR. Some studies are showing that it's better in early PVR modification than late PVR modification. The problem with retinoic acid is it's administered orally, and there can be a lot of side effects from it, but the studies found that most of these side effects were tolerable. But also in women of childbearing age, you have to be very careful as these can lead to birth defects. This medicine can lead to birth defects. Once again, a summary slide of the studies here. Mitomycin C is another antimetabolite. So it was found to be kind of toxic to the retina at higher doses, but it's been found to be safe at doses of 2 micrograms per 1.1 mil. Once again, no clear winner here, hasn't clearly been shown to improve PVR outcomes. So methotrexate, now this drug is causing a lot of excitement. So methotrexate is a folate analog. We like it because we have more experience with it, because as retina surgeons, we actually inject this a lot for intravitreal lymphoma. So the inhibitory effects of it on cell proliferation, especially RP metaplasia, are what are exciting. So there have been a lot of studies done on methotrexate. Most recently, the GUARD trial, which has used ADX2191, which is essentially a methotrexate molecule. Um, they on this We now have phase 3 part 1 results of the GUARD trial presented by Aldera Therapeutics, and it's shown that there are statistically significantly fewer retinal detachments within 6 months, um, about 6 months after RD repair. Um, 13 injections of methotrexate is given at the time of surgery, then every week for 8 injections, and every other week for 4 injections. Now, there are a lot of different doses of methotrexate being studied in various studies. I think there's another large prospective trial in the works right now. So as soon as we get the results for that, we'll have more information. So this is just a schematic for you guys, once again, showing at what stages these different medications and different interventions will likely help with PVR. So good to go over when you get the slides later. What about anti-VEGF therapy? So this is interesting. So PVR is not traditionally considered to be an angiogenic process, right? So the membranes aren't very vascular. Um, what does VEGF do in PVR? So VEGF, its main function here seems to be that it upregulates the PDGF receptor alpha activity, and that's supposed to be super potent in downstream inflammatory and fibrocellular pathways in PVR. A major thing that PDGF alpha does is it down regulates TP53, which increases the longevity of these migrating contractile cells. So if we can target that, then hopefully the contraction stops. But studies with bevacizumab haven't really shown a significant difference. Aflibercept was shown to reduce PVR in animal models, and I think there's a clinical trial going on right now with aflibercept and PVR. So we'll see the results of that as well. Future directions, pathways such as the fast pathway, Rho kinase inhibitor pathway have also been explored for this. So all these studies are kind of in their earlier phases. So once again, we need to we will know more about these medications as the studies progress. This is just a little segue into our surgical discussion now. So this is a patient that I showed earlier who presented with RD symptoms for about 2 months preoperatively. He underwent a successful initial repair, which is a peeling of the star folds, had a scleral buckle done, redetached, had more PVR. So he ended up getting a retinectomy, as you can see here, and he's under oil. We removed the oil and he's doing fine now. Vision is about 2300. This is a sadder case, so I just wanted to demonstrate to you. And when you think you did well, sometimes it doesn't. Sometimes you didn't. So this is a patient here that came in with a 2 month history of hand motion vision VA. Unfortunately, a large posterior starfold, which is never good news for the macula. She underwent repair with C3F8 and a vitrectomy scleral buckle. She came in about post-op week 6, and this is what she looked like. Large stretch holes here and multiple star folds inferiorly. So she recently underwent a retinectomy of about 180 degrees through here, and she's under oil, so we'll see how she does. All right. So now we're going to talk about surgical treatment, which is the fun stuff. So, historical treatment approach for PVR. So, in the 1970s, surgeons said, okay, let's cut these vitreous strands that are visible to us and then use saline to push back the detached retina. But that didn't really account for the role of RPE in PVR. Once we had pars plana vitrectomy, it allowed us to have more tools and to really target these membranes with minimum disruption of the structures of the eye. So the main goals of surgical treatment: repair the retinal breaks, relieve the tractional forces, stabilize the retina, reduce recurrence. With the current methods, anatomic success rates go anywhere from 60 to 80%, and functional success rates are anywhere from 40 to 80%. So when do you go in? This is the great debate, right? So look at the patient age. If they're younger patients, um, they have a much more aggressive course. So go in earlier in these patients and remove that vitreous scaffold. If the macula is attached, please, please, please go in early because you have a chance to save this patient's vision. However, if a patient comes in, their PVR is more mature, their vision is already poor, waiting for those membranes to mature might facilitate better dissection of the membranes because the membranes become less amorphous after several weeks. So also, if you intervene during active PVR, it can create an additional stimulus for proliferation. There have been attempts to make predictive formulas as to who's going to develop PVR after RD surgery, but really they have poor sensitivity and poor positive predictive values. So it necessitates future studies here. Scleral buckle, long-standing use in retinal detachment surgery, really one of the first things used to repair the retina. We perform these episclerally, and we use cryotherapy to close breaks. What do scleral buckles do? They provide vitreous base support. They relieve anterior posterior traction. They displace subretinal fluid away from the tear. They increase resistance to flow through the break, so it's harder for things to flow outwards through the break, and it reapproximates the retina to the adjacent vitreous. In mild PVR, just a primary buckle can be effective, but in severe cases, the reattachment rate's pretty poor with just a buckle. So what happens to the inferior vitreous space here? So essentially, gravity just pulls all those cytokines, all those chemokines into the inferior vitreous. So the inferior vitreous base is where you really see the highest cellularity when you have PVR. So what's the solution here? Okay, remove the vit base. But the problem is, even with the most advanced vitreosurgical techniques, you cannot remove all of the vitreous space. It's just too well incorporated into the ILM peripherally. So the scleral buckle really supports the base against traction, and it's more protective against smaller peripheral retinal breaks. So essentially, we use a circumferential buckle that catches all the breaks peripherally and also supports the base 360 degrees. We want a broad, high buckle, and that's what we need to relieve the traction in all directions. So moving on to vitrectomy, what gauge vitrectomy system do you guys routinely use? Okay, so 23 gauge. Yep. So in the United States, I would say predominantly we're either 23 or 25 gauge now. A lot of 25 gauge surgeons like to use 23 gauge for PVR because of the instrumentation and because of better access. But but a lot of surgeons operate under 25 gauge routinely and sometimes even 27 gauge now. So what does vitrectomy do? Obviously Macumer is the one who really brought about vitrectomy in 1971. It removes it essentially removes transvitreal traction and allows for submembrane removal from the eye, right? So conventionally, of course, 20 gauge vitrectomy is used and it's a great tool, but smaller gauge systems have been used with greater success and are gaining favor. So essentially, what's the advantage of smaller gauge systems? You have early vision rehabilitation because it causes less inflammatory changes in the eye. However, there have been variable studies that have shown that smaller gauge systems, because of sutureless incisions or because of poor angle of trocar placement, can lead to higher rates of hypotony and endophthalmitis after. But once again, the studies are variable on this. Next question. Do you have access to perfluorocarbon liquid at your surgical centers? Okay, so we're divided. Okay, all right. So the reason I asked this is because PFO is essentially in a lot of cases of uh, PVR, it's become like a third hand for a surgeon, right? But it's not used excessively in the United States either, mostly because it's very expensive. So a lot of the surgery that's done in the United States is done at surgical centers. Um, so you have to be more thoughtful about cost, I would say, not so much in hospital systems. But in general, PFO is a very expensive product to use. It's what is PFO? It's the most common perfluorocarbon liquid that's used. What is a perfluorocarbon liquid? It's essentially an inert heavy liquid that has really good optical clarity. And when in the eye, right, it displaces liquids with lower specific gravity, such as blood, vitreous, and subretinal fluid, and it allows the drainage of those fluids through an anterior break or retinotomy or retinectomy edges, essentially. So it's heavy, it sits on the retina, and it also stabilizes the retina when we need to peel because it provides some counter traction. Unfortunately, it can cause histopathological changes in the retina, so you have to be very careful about not letting it go subretinally. So if you can, dissect away the posterior traction on the retina first before injecting PFO, or there's a very high chance that it's going to go subretinally. So we're talking about peeling membranes now, right? So why do we peel? We have to relieve traction, but do we peel ILM as well in addition to the membrane? So the underlying ILM peeling seems to prevent posterior PVR formation. So extending the ILM peel as far as you can beyond the arcades has been shown in a recent study by Yonakawa et al. That this allows for fewer redetachments at 6 months, and they did use PFO as an adjunct in this in some cases. A bimanual technique really helps to remove membranes. So I have a couple of videos here of talking about PFO, using PFO versus no presence of PFO when we peel, and we'll go over those in a second. Before we do, what instruments do we use in peeling PVR membranes? So we have diamond dusted membrane scrapers and flex loops that kind of gently lift the membranes off the surface of the retina, ILM as well. A retinal pick can gently lift up the retina to create a dissection plane. I'm sorry, can gently lift up the PVR off the retina to create a dissection plane. And forceps are what are most commonly used. These are max grip forceps that have more of a flat base, and these are very strong and they can peel dense membranes off, but we also use ILM forceps. So let's talk about peeling. So this is a patient who came in with kind of grade 1 PVR, had a bunch of vitreous pigment. So I thought that it would be a good idea to peel off his ILM in this case to remove a scaffold, to get rid of the scaffold. And as you can see here, there's no PFO here. So what's very important when you're peeling without PFO is to peel towards the fovea first because you do not want that traction to pull apart your fovea. So once you've cleared the fovea, once you've released the fovea, you can start peeling circumferentially away from it, past the arcades, and as far as you can go. So this will really help remove that scaffold, hopefully, for future PVR by getting rid of the Mueller self-foot plates. So this video here, this next one, this is showing a peel with PVR, with PFO in the eye. So here we have detached retina that's been stained. PFO is being injected into the eye now. So Inject the PFO for as far as you need the retina to flatten. So if you're trying to go beyond the arcades, go beyond the arcades. Whatever you need, you can inject PFO a little bit at a time, but you risk more of PFO bubble formation that way. So kind of, it's a good idea to kind of decide early on how much PFO you're going to need in the eye. So as you can see here, a max grip forcep is being used. So as these membranes are being peeled, as the ILM is being peeled along with the membranes, you can kind of see um, that we have to keep the forceps much closer to the retinal surface because we have that weight of the PFO overlying it. So your peeling direction is going to be different. And when there's PFO in the eye, we can typically peel posterior to anterior. Okay. So now we're going to talk about another technique called vitreous wiping. So what is vitreous wiping? So essentially, this technique was described in 2019, and what this does is it removes any vitreocortical remnants. You essentially take a small piece of PVA alcohol from your, essentially a piece of your microsurgical instrument wipe that doesn't fragment, and you use that to gently wipe away the vitreous cortical remnants after staining them with triamcinolone. So that also seems, that also has been potentially shown to decrease PVR formation after primary RDs. All right, now we're getting to the big guns here. So retinectomy and retinotomy. So what is a retinectomy? So essentially, when you have bad PVR and intraretinal fibrosis, that retina has become foreshortened. And you can try to flatten the retina as much as you want, but a foreshortened retina does not flatten. So this needs to be excised. And the way you do that is by making a circumferential incision in the inferior retina here. It's very important to keep the horns of the retinectomy, the horns are the ends of that retinectomy above the horizontal meridian, or if you're doing a more focal retinectomy, which is controversial, at least get the retinectomy edges onto your buccal. Um, and the rules are if greater than a 270 retinectomy is needed, it's better to just complete a 360 retinectomy at that point because we don't want any retinal tags. Um, Very important to remove the anterior retina that's left over, this retina right here that's left behind, because otherwise that retina is avascular. It's going to lead to neovascularization. It's also going to be a nidus for anterior loop PVR. Um, Retinotomies can also be made. Essentially, they're relaxing incisions that are made into foreshortened retina so that when an air fluid exchange is performed, that retina is stretched out, allowing for more flattening. If you do a retinectomy or retinotomy, you have to use PFO, tamponade, and I'm sorry, you have to use PFO in most cases to flatten the retina, and you have to use tamponade with C3F8 or silicone oil. You need a longer acting tamponade in these cases. So this is a case of a retinotomy um, that's been done. This patient here had kind of 360 laser because they had very kind of thinned out atrophic ratty retina, ended up developing PVR that lifted. As you can see here, diathermy is being used to mark the edges of the retinectomy, I'm sorry, because all of this retina back here is stiff, so it doesn't want to flatten. Um, the cutter is then used to separate away the retina anteriorly from the edges of the retinectomy there, marked edges of the retinectomy. People used to use scissors for this, but the 25 gauge cutter seems to do just fine. And here we're removing the anterior retina remnants to prevent neovascularization and anterior loop PVR. So now we're injecting perfluorooctane or PFO into the eye to flatten the edges of the retina and to force the subretinal fluid out. So once the retinectomy edges are flattened, laser is applied. It's controversial as to whether to apply laser under PFO or not, because the burns can potentially be hotter under PFO. So you just have to, account for that with your laser power. And after this is completed, silicone oil is injected into the eye for a longer acting tamponade. So this patient ended up doing quite well. And of course, your trochar's incisions need to be sutured if you inject silicone oil. Okay, so this is another case, very quickly, of a patient who presented initially with the visual acuity of 20/20. There was just an inferior RD here. They had a retinal detachment repair with the vitrectomy scleral buckle. About post-op week 6, you can see a little bit of retinal folding here that's starting. She comes back post-op week 10, and there's just massive PVR inferiorly with foreshortened retina. This couldn't flatten very well intraoperatively. Her vision now is 2200. Post-op week 2 after her detachment surgery, these are the edges of the retinectomy, and bleeding at the edges of the retinectomy are quite common, so this has to be managed with diathermy intraoperatively, but even then you can get bleeding and oozing like this. Um, Also here, you can see about post-op month 1, so the bleeding is kind of decreasing, the chorioretinal scars are forming, so patient's still under oil, doing quite well. In terms of reattachment, visually not so much. Post-op month 3, her vision drops to count fingers at 1 foot. She develops this massive epiretinal membrane. So I went in, peeled off the membrane. Post-op month 1 after that surgery, this is how her retina looked, and this is how she looks post-op month 3, and her vision's improved to 20/80, which with from 20/20 to 20/80 vision doesn't seem like a win, but in PVR world, it's definitely a win. So we're going to finish up here with a few other components of PVR surgery. So lensectomy. Do a lensectomy either if you have a poor view or if there's a lot of anterior PVR, because the capsule of the lens can form a scaffold for anterior PVR and further contraction. So lensectomies, if there's not a lot of anterior PVR, try to save the anterior capsule and go through the pars plana with a cutter or a fragmentome. And that also facilitates future IOL placement. Tamponades for PVR, essentially they're used to tamponades and retinal detachment surgery in general are used to provide surface tension against the break. And essentially this prevents further fluid flow into the subretinal space until the retinopexy or cryopexy scars mature. It can be done with air, gas, or oil. So longer acting tamponades like oil and C3F8 had similar visual outcomes, but both better than SF6, which is a shorter acting tamponade, in the silicone oil study. But at 6 years, all of this evened out in patients um, who had macular reattachment at 3 years. The EVRS study really didn't show a difference in outcomes between oil and gas. Smaller studies seem to show one is better than the other. It's really surgeon preference. Silicone oil, there are two different viscosities we use of this, 1,000 centistokes and 5,000. One isn't really better than the other, except for the 5,000 centistokes oil does not emulsify. So in patients that have really bad PVR, have 360 retinectomies, usually 5,000 centistokes oil is placed and just left in the eye because there's no thought of oil removal down the line. After oil removal, the rate of redetachment can be anywhere from 3.5 to 34%. So the pros of silicone oil, it's a longer tamponade, there are no travel restrictions. There are not a lot of head positioning requirements as compared to gas, except for not laying flat on your back, of course. Patient can see better, you can see better into the eye. There's a lower chance of hypotony as well, and you can re-op under oil. But the cons of it, of course, you need to remove it surgically. It can cause keratopathy, it can emulsify, and it also causes IOP elevation. Another big thing that they don't that we talk about but not as much is silicone oil perisilicone proliferation. So essentially what silicone oil is doing is being a longer acting tamponade, it's concentrating all of those chemokines, cytokines, everything into the inferior retina. So if you do not have a retinectomy, you still have a quite intact inferior vitreous base that hasn't been shaved well. This can be an easy nidus for future PVR formation. It's called PVR soup colloquially. Heavy silicone oil is used in some parts of the world. It sinks because it's heavier than water. It seems to be a great adjunct in inferior detachments, but really the HSO studies show no anatomic or visual acuity differences in inferior PVR. So last but not least, let's talk about subretinal PVR. So subretinal PVR essentially is formation of subretinal bands, if or the napkin ring configuration like we talked about, which that really needs a retinectomy to remove. You lift the retina off and then peel off the tissue. But in cases of bands like this, you can make punch retinotomies next to the band, go in with your forcep, and you can pull the band out in this way. It's important. Some people advocate to go right over the band to break the traction. Some people say don't do this because if there's still traction, you can't access the band. Um, you can try whatever technique you'd like. You can use bimanual. You can just use one hand and pull it at a tangential angle. Um, Only remove them if they're preventing retinal flattening, though, which about two-thirds of subretinal bands don't really need to be removed. This is just a case of a subretinal band patient. So he came in once again with about 2 months history of a retinal detachment that seems to be very common in our area of practice. So he had a large subretinal band right there. So I removed that with the punch retinotomy and lasered around it. Also put some supporting laser in this area on the buccal. He's doing well, still reattached about a year later. All right. So last poll question of the day. Which of the following is the best technique for PVR management? There we go. Okay. So a majority of you guys voted it depends on the situation, which was the whole point of my presentation to show you guys that PVR is not a one size fits all issue, right? So it all depends on the patient goals, how bad the patient was at presentation. Do you need the expansion of the gas in the short term, or do you need the long-term use of silicone oil? Are you going to do a buccal, or do you think you need to do a retinectomy based on the pre-op presentation? So a lot of different factors go into this. So that concludes the presentation here. So these are my citations. Wanted to thank Dr. Kitchens and Dr. Strand, who helped me with some of this, and also Andy Lawrence and this entire Cyberside crew. I mean, you guys are just amazing. It's just been great working with you guys. Thank you. Questions? Okay, so first question, when the retina is detached, it should be anoxic, not releasing VEGF. Photoreceptors are dead. Yes, they die later, but remember, VEGF is released by not only dying photoreceptors, but it's also released by just from the bloodstream with the breakdown of the blood retinal barrier. So it's not just from anoxic retina, but the retina doesn't start off anoxic, remember, because it's still getting blood supply to its inner layers initially through the inner vasculature before that breaks down as well. Another question here, what do you think about methotrexate to prevent PVR? So in my clinical experience, it's been it's been great in preventing PVR in high-risk patients. I actually use it per the GUARD study protocol in some of my patients who I know either had earlier grade A or grade B PVR coming in. I try to peel epiretinal membrane in these patients, and then I do guard study protocol on these patients in terms of injections, which is I sometimes I can do an injection at the time of surgery, sometimes not, but I try to do the 8 weekly shots followed by 4 monthly shots in these patients. What are the top two treatment standards for PVR for meta-analysis to be done on this subject? So really, I would say in the US, the top two treatments that we're looking at are methotrexate and oral retinoic acid. Those are the ones that are most well studied. Um, how to avoid PVR in children undergoing RD surgery? That's a very complicated question, and I don't think you really truly can avoid it. But I think it's just it's a children are a whole different beast. So that will be more of a pediatric retina surgery presentation that we can talk about. But there's not a really good way to prevent PVR in children um, just because of how um, cellular these children are, how robust their immune systems are. Are there genetic factors that predispose to PVR? I'm sure there are because in in practice, most retina surgeons will tell you we have patients who come in that have been detached for 6 months that have completely, have retina that's completely pliable, lays down perfectly well, does not redetach. We have patients that have been detached for less than a week that have early PVR. So there are genetic factors, and I think there are a lot of studies going on this, but we don't have, once again, a clear answer yet. Any benefit of staining membranes with brilliant blue versus ICG? So this is an interesting question. So ICG is not technically FDA approved in the States for peeling. So Brilliant Blue is really the first FDA approved stain that we can use in treatment, although ICG is the most popular. I think that brilliant blue is likely safer than ICG because ICG can cause phototoxicity to the retina, and there have been cases of just standard epiretinal membrane peels with ICG that go to hand motion because of this ICG toxicity. It's very rare, but it can happen. But it's still used because the staining capabilities of it are quite high, and a lot of what we use in retina surgery is based on your training preference. I trained with both, so I use both. With Brilliant Blue, I tend to use that more if I see a lot of traction and there's a higher chance of migration subretinally when I inject the dye. But otherwise, I use ICG as a standard. Okay, so would you please suggest some perioperative tips to avoid post-op PVR? Okay, so the most important thing in my experience, that I think you can do to avoid post-op PVR is remove as much of your vitreous as possible. Because the vitreous is what really causes the scaffold, the inferior vitreous really, the base of the vitreous is what really, it allows for scaffold formation essentially for these PVR membranes. So the more vitreous that you can successfully remove, the better off you're going to be. If you already see early PVR, in my experience, um, peeling the ILM in the macula seems to be more protective for postoperative macular PVR, because that's what we're really trying to prevent here. If we can get the macula to reattach and sit flat, patients tend to do pretty well here. In your experience after RD, how much time does a patient have to restore vision? Once again, very variable. I wish I had a great answer for this. Um, it depends on the patient. It depends on your patient population. I've seen patients. The conventional wisdom is try to reattach that patient as quickly as possible because you want to prevent photoreceptor death. You want to prevent all these anoxic effects. But essentially, we don't really know who's going to have a great visual outcome and who's not, because we don't know who is getting this reactive gliosis. So as a rule, that's why we try to say, since we don't know who's going to have these downstream inflammatory effects, let's just repair everyone as if they are a PVR candidate. So which means as quickly as possible. So as quickly as you can get them into the OR, I would say try to restore their vision. Do you use any dye for staining PVR membranes? So in my experience, I mean, I use ICG dye to peel ILM. PVR membranes are more of a negative staining. Sometimes triamcinolone can highlight them, but it's more of a negative staining effect similar to an ERM, that you know it's there based on movement and based on how the retina is moving when you're peeling them. All right. Any other questions here? Vitreous was removed during vitrectomy, then why does PVR develop? Because, great question. And that's, once again, we're coming back to it. Number one, there can be vitreoschisis, right? Which is there's the vitreous layers are separated. So you think you have a PVD, you think you remove the vitreous, but there's actually a layer that's formed on the surface. Or you just have done an incomplete vitrectomy peripherally. So you really have to be careful. Either you shave very, very well to the vitreous base, right? And try to decompress that vitreous base as much as possible. Or you put a scleral buccal that is very high, and not very high, but moderately high and posterior to provide kind of counter traction to any membrane formation. After 3 years, do you try to fix PVR? Yes, I try to fix any retinal detachment that appears on my doorstep, if possible. Um, At the very least, it's because if these eyes start to develop anterior PVR, they can basically become very hypotenuse and become tisical. So if a patient is motivated, then I will try. Okay. All right. All right, guys. Does methotrexate enhance PVR on tumor-bearing women? That's a great question, Boris. I don't know the answer to that. But I can do research and get back to you on it. All right. I think we're pretty much done with the questions. Um,
Perfect. Thank you, Dr. Reddy. I think we
yes,
can
sir.
stop here.
Okay,
And
great.
thank you again for your time today.
Thank you. Take care. Take care, guys. Thank you.